Hello everyone and a warm welcome to today's webinar. My name is Jason Merdefrutos and I'm very pleased to have moderated this discussion on behalf of the European Public Health Alliance as part of European Mental Health Week. This event is a collaboration between IFA and the University of Sheffield in the context of the InMind project, a European-funded Marie Curie Action. This project aims to, for the first time, explore the similarities and differences between beliefs that have been typically associated with mental health issues and other strongly held but widely shared belief systems, such as religious and political ideologies. Dr. Almudena Trucharte, who you will hear from today, is the principal investigator of this project. She is an early career researcher specialized in mental health and clinical psychology. In this project, she is being supervised by a professor in clinical psychology, Richard Bentall, one of the greatest experts in research in psychosis, who is also with us today. The plan is that we at IFA will host Dr. Trucharte's placement at the end of the project, helping her translate their research findings into actionable policy recommendations. Now, back to the webinar titled Between Convictions and Psychiatric Labels, Beliefs, Polarization, and Mental Health in a Changing Europe. It touches on an increasingly relevant and sensitive topic. In the context of growing polarization and rapid societal change, the boundaries between strongly held beliefs and clinical concerns are not always clear-cut. This discussion invites us to reflect on those gray areas and on what they mean for mental health and public health policy. Rather than offering simple answers, today's conversation aims to open up space for thoughtful reflection and dialogue. We encourage you to engage critically and listen closely, and be ready to reconsider your perspectives. And now, before we share the recording from that session, it is my pleasure to reintroduce our speakers. Richard Bentall, professor at the Department of Psychology, Faculty of Science at the University of Sheffield, and Almudena Trucharte, postdoctoral fellow at the same department and principal investigator of the InMind project. And with that said, let's get started. Over to you, Almudena and Richard.
We just get our slides up.
Okay.
Here we go.
Okay. I think it's fine.
Okay, so all right. Okay, so I thought we think it would be a good idea to start with a controversial and difficult case study. So I'm sure everybody here is kind of familiar with the name of Anders Behring Breivik. Anders Behring Breivik carried out some appalling crimes, which I'll go into in a few seconds. But from our point of view, one of the interesting things about his case is it triggered not just a nationwide discussion about the boundaries between mental illness and political extremism, but actually an international debate about that. So on the 22nd of July 2011, Breivik detonated a homemade car bomb in the government quarter of Oslo, and the bomb was so powerful that it instantly killed 8 people and it wounded 209 people. Immediately afterwards, he travelled disguised as a police officer to the island of Atoya on, I hope I'm pronouncing this correctly, Trimforden Lake. And on the island, the Norwegian Labour Party was holding a youth summer camp. So there were lots of young, political, active Norwegians on the island. He managed to get a lift over to the island on a ferry. There he gathered everybody around him on the pretext that he was inquiring into their safety given the bomb attack in Oslo. But as soon as people had gathered around him, he pulled out from a bag, he pulled out pistols and automatic weapons, and he began a shooting spree. And over the next few hours, he wandered around the island and actually shot dead 69 people and wounded 66 other people before he gave himself up by the police when the police finally arrived from Oslo. Before the attacks, he had circulated online a 1,518-page manifesto which explained his motives. It was entitled 2083, A European Declaration of Independence. And it included a lot of copied and pasted stuff from far-right websites. But the essential core feature of it was that he complained about what he said was the Islamification and feminization of Europe. And he saw himself as part of a secret organization which was fighting this corruption and destruction of European culture. And his ideas echoed a widely held conspiracy theory, which had been circulating for some time and continues to be circulated today, which is called sometimes the Great Replacement Theory. And this is a theory that for some reason, there is a secret cabal of European elites who are conspiring to replace the white Christian population of Europe with people with black skin, dark skin from Africa or the Middle East. So when he was detained, he was assessed by two very distinguished Norwegian psychiatrists. They wanted to decide whether he was mentally ill, in which case he would not be convicted of a crime, he would instead receive psychiatric treatment, or whether he was knew what he was doing and if he was culpable for his crimes. And they concluded, actually, they interviewed him with a standard psychiatric interview procedure, which I've used quite a lot in my career. It's called the Positive and Negative Syndrome Schedule. And they concluded that his beliefs were irrational and extreme and paranoid, and that he therefore suffered from, he was diagnosed as suffering from paranoid schizophrenia. This produced an uproar in many other mental health professionals in Norway who thought this was absurd and thought that the assessment had not been carried out sensitively enough. It produced an uproar in Breivik himself, who thought the diagnosis was insulting. It produced a massive debate amongst the Norwegian public, and that debate cascaded abroad. So you'd find psychiatrists and psychologists in other countries writing papers about Breivik and trying to disentangle whether he was mentally ill or just a political extremist. In actual fact, he was found guilty at trial and he was given the maximum sentence possible, which is 20 years in Norwegian law. But this case and the disagreements amongst mental health professionals just illustrates how difficult it can be sometimes to tell the difference between a pathological belief and a non-pathological belief. So we thought we'd kind of give people maybe a bit of a flavour of this by holding a kind of quiz. So if you hold up your phones to the QR code, what you'll see, you'll be able to carry out this quiz. And all we've got is, we've got 11 beliefs, some of which have been taken from psychiatric patients, some of which are kind of conspiracy theories, and some of which are just mundane, everyday beliefs, or factual beliefs about things which maybe most people don't know about. And we just want you to kind of look at these beliefs and decide whether you think they're plausible or not. And you'll have a few seconds for each one. There's 11 beliefs in total. So should we start?
Yeah, but we only have two participants.
Oh, so
Yes,
three. Okay, you have to wait just a minute. People, it takes a bit of time to kind of log on. Okay. Maybe most people don't want to do it. Right. Okay. There's no trick questions here, I should say. And, we're not going to basically kind of reveal anybody's answers, or we're not even going to look at the summary. We're just trying to give you a flavour of why this is a kind of difficult kind of issue. Well, should we wait until we get up to at least 10? So should we say? Okay. So be brave. Just okay, 9 of you are on. Okay, that's good. That's great. Come on, number 10. You can do it. Oh no. I think we probably have to go with 9. Okay. All right. Let's do that.
You can read the statements.
Oh, okay. So I have to put them on my phone then.
Okay.
My phone's off, so I can't do that.
But you can read from here.
Okay.
Okay.
Okay. Here we go. Okay. This is the first question. The contrails left by planes are chemicals deliberately dispersed into the atmosphere for population control. True or false? Okay.
So, no.
Okay.
So let's see.
Okay, the Kingdom of Congo maintained a network of relay runners who could deliver messages across the entire kingdom in less than 5 days. True or false?
We need to move.
Gdansk has a law requiring buildings over 3 stories tall to maintain a colony of pigeons. True or false?
Let's see.
Okay. Princess Diana's medical care after the crash was deliberately sabotaged, causing her death. True or false? Okay.
Yeah.
Yeah. Okay. Somebody cut your hair at night to make you look unattractive and unapproachable. True or false?
What?
Denver.
No.
No, we've got the wrong one. That's good.
No.
Denver International Airport has a secret government base underneath it. True or false?
There is a debate here.
There we debate. Yeah. It's not so clear. Yeah.
Okay.
Another one. You are sometimes followed by people you know who are wearing disguises who are out to cause you harm. How true or false is that? Okay. You have another one? Okay, the capital city of Atil has a legal system requiring judges to be fluent in 4 languages. Your neighbors are spreading nasty rumors about you and tormenting you. Okay. The writers of The Simpsons are involved in a secret group with access to future events. Okay. Is that it? Are we at the end?
Yeah.
Okay.
And the last one?
Oh, it was the last one. Yeah, okay. The Indian Ocean experiences waves from 3 different directions that meet exactly every 12 hours. True or false? Okay.
There's a debate here.
Okay. Okay, so as I say, we're not going to sort of give you feedback or go through them in detail because there's not enough time, but I guess you've probably beginning to already get a sense of maybe a way in which I bet you probably noticed or made a good guess about which one of those came from psychiatric patients. You might be just beginning to form an idea about why those beliefs might be different. But Almudena is now going to talk a little bit about what psychiatric patients generally believe when they have these pathological beliefs.
Well, Richard, when we talk about the beliefs that we typically find in people with severe mental...
The next one.
Yeah. And we talk about the beliefs that we typically find in people with severe mental illness or mental health difficulties. We use the word or the term delusions in a clinical way. So we need to acknowledge that we refer to delusions in psychiatric or psychological context to refer to the pathological beliefs in the sense that they are very difficult to change or they are not shared by other members of the culture, among other criteria. And here we have the 5 most common delusional beliefs that we find in the clinical practice. And I'm going to explain later on all of them, but what I want to highlight here is that in this meta-analysis, we call meta-analysis the kind of studies that we have like a synthesis of all the quantitative literature about a topic. So this is a very huge meta-analysis with a lot of studies included in it and with a very large population. So what our research team found in this study is that the most common delusional theme was paranoia or persecutory delusions, followed by the rest of the themes. But what is more striking is that these results were consistent across 30 countries and cultures, and that these themes are not just random symptoms, they represent existential dilemmas or existential human concerns. For example, the most prevalent one, paranoia, who can I trust? I mean, we are social animals. Of course, one of the most important things to us is who can I rely on? Followed by grandiosity, how do I compare to others? How is my social performance? Reference, which events matter to me? Do I have some autonomy in my life? Or with religious belief, what is my life purpose? So it is no surprise that because they are not just random symptoms, and they represent these existential dilemmas, that we can find that up to the 60% of people who suffer from psychosis or severe mental illness can experience this kind of beliefs, but also that around 7% of the general population can have this kind of belief as well. So you might be wondering, how is that possible? So when we talk about delusions in the clinical practice, we need to take into account the idea of a continuum, where in one side we have the normal, common, everyday concerns, experience, like for example, following the example of paranoia persecutory delusions. You might know people around you, or maybe yourself, that in some social situations you can become more suspicious, you can have more levels of mistrust or maybe interpersonal sensitivity. So you can have the feelings, the experience, thought, belief that others are looking at you, maybe even they are laughing at you or they are staring at you. At this moment, I have the feeling, I cannot see anyone, but I have the feeling that a lot of people is looking at me, probably it's a right feeling. And then at the opposite end of that continuum, we have what we call persecutory delusion. So we move around the continuum. What determines what is pathological or not is the frequency, severity, and distress of that experience. So maybe, Richard, you can perhaps tell us a little bit more about how in the past people have tried to distinguish between this kind of psychiatric beliefs and other belief systems.
Right, thank you, Almudena. Well, as you know, as Almudena has explained, although these are these big five themes are the common beliefs of people with, say, a diagnosis of schizophrenia, they are also beliefs which are held by quite a large minority of the general population generally. So you can find people who are a bit paranoid, but not psychiatric patients. So this has taxed the greatest minds of psychiatry going back to the beginning of the 20th century. People have tried to figure out, well, what is it that makes delusions different then? And typically, what people have done is compare delusions to what we call mundane beliefs, so everyday beliefs. So, for example, a mundane belief would be that I think my train from Sheffield to Liverpool will leave the station at 11 minutes past 6 this evening. Okay, that's a mundane belief. Or I believe that Sardinia is a nice place to go on holiday. So if we compare delusions with those kind of beliefs, we see a lot of differences. So, for example, delusions, this is the first thing which psychiatric manuals generally say, they're held with great certainty. My belief that the train will leave at 6:11 tonight is not held with a great deal of certainty, not least because I've got some experience of the inefficiencies of our train system. Delusions are highly resistant to evidence. It's quite difficult to persuade people that the delusions are wrong. It's not impossible. Psychologists have developed specific reasoning techniques they call cognitive behavioral therapy to help people with delusions. I spent quite a lot of my career working in clinics with these patients. But it's dead easy to change mundane beliefs. I just get a notification from the train company that my train is cancelled, and my belief changes instantly. Delusions are also what we call multi-propositional. What this means is they're not just one proposition or one belief. They're a network or a set of beliefs which are interconnected. So a patient might feel, for example, just thinking one of my old patients might feel that they are being persecuted by the intelligence services, but also think that there are television cameras around the town keeping watching him, and also might think that his next door neighbor is actually an undercover agent who's spying on him. So obviously, as you realize, delusions are highly emotionally salient. So people are very distressed by them, as generally speaking, preoccupied them, they can't stop thinking about them. And as Almudena has explained, they seem to capture these core existential themes which actually worry all of us. All of us worry about these things at some point in our day lives. And finally, I should just say one thing which also people say that delusions are different. And this is true sometimes, but not always, which is that delusional beliefs are preceded by anomalous experiences, strange perceptual distortions. And the most kind of common one, always been most noted of this, is called delusional mood. And this is the sense that the patient who is about to become deluded has this idea that something is going on. They don't know what. There's something in English language, we would say something in the offing, some idea that something is about to happen, something strange, something's not quite right. And when the delusion arises, it resolves that feeling. So all of a sudden, everything seems to make sense. Okay. Oh, I'm being spied on by intelligence agencies. That explains what's going on. So these are the way in which psychiatrists and psychologists have traditionally distinguished delusions from other types of beliefs. So I'm now going to ask Almudena, do these criteria actually work?
Well, what we are seeing is that this criteria really doesn't work. In part, thank you. If you have a look to the table, just as Richard already pointed out, there is nothing in common between delusions and this kind of mundane belief. So we were wondering in our project what could be a good comparator, and why not we decide to see, for example, other strongly held belief systems like political and religious ideologies could be a good comparator of delusion. And now, if you have a look at the table, you can see that they share almost every property or almost every dimension that we use to do the clinical diagnosis with the delusional beliefs. So our next question is, what is really the key difference between them? So as you have seen in the quiz, it's not the content of the belief itself. It is not resistant to change. For example, Richard, when is the last time that you win a political argument?
No, political argument with a friend. There's no point where your friend goes, how could I be so stupid?
It is not the emotional relevance that this kind of belief have in your life. So what it is, and if you have a look at the last property of the table, you can see that delusions are not shared with others. They are idiosyncratic beliefs, but mundane, religious, and political ideologies are shared by others. The great replacement theory has been spread. Religious and political ideologies can be spread, but not delusions. They don't propagate. And the thing here is that we don't really understand why. We are trying to figure it out in our project. We have some hypotheses that we would like to test. For example, maybe it is because that people who suffer from delusions have more difficulties and less social opportunities to share the belief with others. What we already know is that people with persecutory delusions has a low sense of belongingness and also suffer a lot from social isolation. But the problem here is that we don't know what comes first. It is the social isolation and then they develop the paranoid belief, or is the other way around? We don't know, or we don't know yet. And our second hypothesis is that maybe it is because they have some kind of social cognitive deficit in the sense that they have difficulties to understand others. We don't know. But what we already know is that people who suffer from delusions have an ability to calibrate and align belief with others. So we would like to go further in that sense. And Richard is going to tell us a little bit more about this idea of transmissibility and psychiatric belief, but also with ideologies and other kinds of belief systems.
Okay, thank you, Almudena. Well, as Almudena says, we seem to have this difference between delusions and other types of beliefs, where delusions are held, generally speaking, by, even though they reflect these general existential themes, they're actually only held, this particular belief is only held by one person. That's the person with the delusion. So, and this actually highlights something about beliefs in general, which psychologists and psychiatrists have been pretty kind of blind to over the last 100 years or so, which is that beliefs in general are usually not just produced by one person. They're produced by groups of people. We could say that they are co-produced. So religious beliefs, religious ideologies, and political ideologies, they're not authored by one person and then spread. They're created by groups of people. And this points to an important aspect of human psychology, which is the way that we form groups with other people. So human species is a primate species. There are about 500 primate species in the world, a little bit more than that, actually, but roughly 500. And one feature of primates, all primate species, is that they're highly social. And most primates, orangutans are the exception probably, but most primates go around in groups. So chimpanzees go around in troops. They belong to gangs, you could say. They fight sometimes, the gangs fight. But the important thing about a chimpanzee troop is it's limited in size to the number of individuals which each chimpanzee can know. The group only works because each person in that group knows all the other people, all the other chimpanzees in the group. Human groups are very different, uniquely different. There's a wonderful phrase from a historian, actually, called Benedict Anderson, who was interested in the development of nationalistic beliefs. Anderson was trying to figure out why it is that we form these kind of, these kind of, he was interested in, say, nationalism. And he said that human beings form what he called imagined communities. That's imagined, not imaginary. These communities are real, but they're far vaster, far greater than any community which a chimpanzee could belong to, because it includes people who you will never meet, who you don't know anything about, but you still think you and those other people belong to the same community. So, for example, if you're a Christian, you believe perhaps in the doctrine of the universal terms Catholic Church. It doesn't mean Catholic in the way we normally think about it, but that there is a universal bond between all people who are Christian throughout the world. You belong to the same group. You're connected to each other. You don't know each other, but you're connected. Same if you're a Muslim and if you feel about the Ummah, which is a kind of Muslim concept which has the same idea. Same if you say in the United States that you are a Republican. You're not going to know all the other Republicans in the United States, but nonetheless, you feel a sense of belonging to them. You belong to this imagined community. And deluded people, so far as we can see, don't seem to form imagined communities in the same way, or at least we don't think they do. So, for example, paranoid patients do not gather in the corner of a psychiatric ward and have a little discussion amongst themselves to decide who the true persecutors are, and then work out how to go and persuade other people. But religious people do that. Political groups do that. It's exactly what they do. So one way of thinking about this, and this is just a hypothesis, it's a speculation, but it's something we can look into, is that we can think of as a kind of continuum between delusions on the one hand, ordinary healthy beliefs in the middle, and extreme beliefs on the other hand. So it turns out that for most people are, when we form these groups, we say we form social identities. The group becomes part of who we are. We define ourselves in terms of the group. So when we meet people at a party, we don't describe ourselves in terms of our personal characteristics. We don't say, "Hi, I'm Richard Bentall. I think I'm a person of above average intelligence. I'm quite agreeable, not all that conscientious. I tend to be quite neurotic and I'm a bit overweight." We don't say that. We say, "I'm a psychologist. I come from Liverpool." In Britain, we'd say I'm a Scouser, because that means I belong to this imagined community. I feel a sense of brotherhood, sisterhood with all the people in Liverpool. So we internalize these communities, and then we make them part of who we are. And it turns out that in ordinary people, that the more we do that, the more groups we belong to, and the more flexible we are in our identities, then the more resilient we are to stress. So it's good to have lots of imagined communities. You might think that you are, as I say, for me, a Scouser. You might think you belong to a particular profession. You might think you have particular religious beliefs. You might think you belong to a running club or whatever. More of those kind of things, the better. Deluded people, we think, don't seem to form these communities at all, or very little. And then what about people with very extreme beliefs? Well, it looks like they have, you could call them hyper-identities. They have very, very strong identities which dominate their entire lives. They have only one overriding identity which crushes all others. So, and these identities are characterized by a sense of extreme, we call it identity fusion. So what happens is that the distinction between we and I disappears. We and I are the same thing. That's why people will make extreme sacrifices, maybe even sacrifice their own lives for these groups. And also another term which we can use is that they're narcissistic. And what this means is that the person feels that their identity group is exceptional, perhaps historically important, more important than any other identity group, but also that this exceptionality is not recognized, that the group is disrespected. Sometimes, of course, that's fed by actual experience. So, for example, Islamism has been fueled by, actually, realistically, some of the actions of Western powers in the Middle East going back over the last century or so. But these identities become, I say, hyper identities. They become highly rigid, and they dominate all other identities, and they lead people to do extreme things. So that's a kind of idea about the relationship. What really is important about the distinction between, on the one hand, the beliefs of psychiatric patients, which cause great distress to those individuals, if not to other people, and which actually create a lot of problem for people's lives. That's why we have to give them help. We've got flexible, multiple identities of people who are living healthy lives. And then we've got these extremely inflexible, hyper identities of people with religious or political extremist beliefs. So I think that's kind of it. So we're ready kind of to take some questions, criticisms, discussions, thoughts.
Well, thank you very much for some interesting discussion. And indeed, we started receiving some questions. Maybe we can start with, I don't know if it's an easier one, but it's definitely one that everybody can relate to. Would the research or your research in particular tell us about how to talk to someone, maybe a friend or a family member who holds an extreme belief? Are we able to change their mind, or how should we engage in conversations with these people?
One of the goals, that's the more we understand about how these belief systems work, the more we will be able to intervene. Not with I think it's very important in this thing that you don't approach other people who have different beliefs with a sort of idea that they are wrong, we are right. And one of the things I used to say to my clinical students when I teaching them how to do clinical interventions for people with delusions, I say that one important thing is that when you meet somebody who's got a really strange belief, just remember the fact that no matter how crazy it might seem, it is their best attempt to understand what is happening in their world. So we know a little bit about how to approach people with extreme beliefs, probably at either end, in fact. There's quite a lot of research about sort of, for example, interesting enough, by people like hostage negotiators and forensic psychologists on the one hand, when it comes to talking to people with extreme political beliefs. And on the other hand, we have the development of the cognitive therapy techniques for people with delusions. A really important thing which we know so far, the common feature of all that is that you have to be able to empathize with the person you're trying to deal with. If you're negotiating with, I know people who've done research on looking at tapes of FBI interrogations of Islamist terrorists. And it turns out that if you want to actually get them to cooperate and tell you stuff, best thing is actually to be quite kind to them and actually show that you can at least take, to some extent, their point of view. Threatening them doesn't work. And the same is true when it comes to working with people with delusions. You have to start from a position of like, your belief is a bit strange, but I don't quite understand where it came from. Maybe we can work together to try and make some sense of it. That's the kind of approach there. And even in everyday politics, there's an approach developed by Turkish political activists, which has a strange name, which is called radical love, which is the idea is that when you go around canvassing, you're knocking on people's door, what you don't do is preach them. What you do is actually try and understand, first of all, understand their concerns. And then you start to talk about how your political kind of program will address those concerns. So, but we ideally we would like to learn more. And the aim will be to try and make not get everybody to believe the same thing. That would be a horrible world for everybody to do the same thing. But to get it so people could be more flexible and more respectful of other people's beliefs, because then we'd end up with a kinder world, and one which would be much better in all sorts of different ways. I hope that's a good answer.
Thank you very much. We got another question in the chat as well, and I'm going to try to reformulate it to make it a bit shorter. But someone asked, basically, how can you reconcile merging the we and the I in extremist beliefs with clinical experiences where the boundary between self and environment is disrupted? Or in other words, how can your argument about merging we and I in extremist beliefs relate to experiences where the boundary between the self and the environment become blurred?
It's a very good question. A very tricky one. Well, I can try, and you can help me.
I can have a go as well.
Well, we were talking about it yesterday. In fact, that sometimes when we have this identity fusion, I cannot say
identity fusion.
Thank you.
Yeah. When your personal identity and your social identity become one.
Fusion. It is because probably you have a very strong held belief and you truly believe in it, but sometimes, okay, I don't have to touch anything. And sometimes is that people who have like social isolation, they are from deprived neighborhoods, so they have a lot of difficulties. They can find sometimes in this kind of extremisms and in this kind of beliefs, they can find like a family, they belong to a group, they have like a sense of themselves, and sometimes that is why it becomes that fusion. The problem is, at this moment, I don't know how to tackle it or how it could be the best approach, probably trying to gain this flexibility about social identities and not just to form one, just to have the sense of belonging that you are part of the world and you are part of a humanity, identification.
Yeah, maybe I can sort of try and address it in a slightly different way.
Okay.
Which is that, so I'm not quite sure about this characterization about patients, psychiatric patients, having no clear boundary between themselves and the world. I'm not quite really sure that that's what's going on, actually. I know there's a kind of tradition in psychoanalytic approaches, which is that's the case. But I think, in terms of the framework which we've just described, it can be put like this. For people with delusions, there is no we. It is just I. And one of the things you'll notice when you're doing that quiz, it was probably quite easy to spot delusions. Why? Because they're intensely personal. People don't have delusions about other people, but all their delusions are about themselves. They are alone in the world in their heads. They are, it's all about them. In the case of people who are extremists, it's all we. It's kind of like the we is I. The two are the same. And in kind of healthy functioning, what happens is that we have a we and we have an I. and we can navigate our way mentally between when we're talking about I, when we're talking about we can move between those two perspectives.
Well, very much. Unfortunately, we have time. I just wanted to say a huge thank you, especially to our speakers, Professor Richard Bentall and Dr. Almudena Trucharte, for this insightful discussion. And also thanks to all of you for your participation. We hope that today's webinar has helped deepen your understanding of how different types of strongly held beliefs relate to mental health in a changing European context. The recording, as we said before, will be available on IFA's website in the coming days. And we also encourage you to keep an eye on the outcomes of the InMind project as it progresses. Thank you again for joining us, and we hope to see you at the future IFA events. Goodbye.
Thank you.
Thank you.
Thank you.